does glutamine still has a part to play? Well, today we will discuss why glutamine is an issue. I will discuss some metabolic pathways and then two confusing studies with results which were quite contradictory to previous studies, MetaPlus and Redox trial, and then a hypothesis that could explain the controversy. Well, glutamine is the most abundant amino acid in plasma. It's a key nutrient in the body's response to stress. It was originally and is still not always a component of parenteral nutrition, and the reason is that it is considered as a non-essential amino acid. However, it may become essential during stress. At least that's a hypothesis. Well, this is an older study we performed, and we measured plasma glutamine concentration in acute ICU admissions. And we found that low plasma glutamine was present in 30% of the patients, and that low plasma glutamine was predicted mortality independent of the Apache 2 score. This newer study from Sweden measured plasma glutamine in all ICU admissions, and the results were a bit, well, difficult to understand. They found that low plasma glutamine on ICU admission was associated with low ICU but high long-term mortality, and that normal to high plasma glutamine was associated with high ICU but low long-term mortality. I don't understand, but that's what they found. At least they could not predict plasma glutamine concentration by Apache 2 score, indicating that we cannot predict plasma glutamine from severity of disease. And when they did a multiple regression analysis, they found that both low and high plasma glutamine were associated with mortality independent of age and severity of disease. So it's much more complicated. This recent meta-analysis reviewed parenteral glutamine as part of parenteral nutrition, or sometimes enteral nutrition, and so these were the studies. Glutamine was part of parenteral nutrition. Parenteral nutrition was often started late if enteral nutrition failed, so the patients had an energy deficit. They often included oncology patients and excluded patients with renal and liver failure. And glutamine was administered in a nutritional dose. And the meta-analysis showed that mortality was lower, infections were less, and length of stay in the hospital was less as well. And there was no signal of harm. This is also a recent meta-analysis, and it studies the effect of peri-operative glutamine supplemented parenteral nutrition on outcome. They included 16 randomized controlled trials, and they found that glutamine-enriched parenteral nutrition reduced infectious complications, reduced length of stay, reduced post-operative negative energy balance, and had no effect on mortality. Why would glutamine be beneficial? Well, first, it's a source of energy. When glutamine is converted to glutamate, and next to alpha-glutarate, there's ATP delivered, and alpha-ketoglutarate can enter the citric acid circle and thereby generate energy. But there's more. During sepsis and SRLF, glutamine is continuously released from muscle. And glutamine serves as an energy source, as a nitrogen transporter, and as a metabolic precursor for rapidly dividing cells such as enterocytes and immune cells. So the idea was that glutamine supplementation could improve host defense. This, I think, is a very important review. It's an older publication, and it shows that interleukin-1 production and phagocytosis in macrophages and RNA and protein synthesis and IL-2 production in lymphocytes is glutamine dependent in a dose-dependent way. These were in vitro studies. Thus, it suggests that glutamine depletion could influence immune function. So, during stress, glutamine is released, on the one hand, as a stress signal, on the other hand, as a substrate precursor or source of energy. The stress signal is that glutamine provides cellular protection by heat shock protein 70 production, which protects tissues. It also limits the inflammatory response. Glutamine also loosens the binding of nuclear NF-kappa B to the nucleus and thereby limits the inflammatory response. That was the idea. In addition, as I've mentioned, glutamine provides metabolic support to immune cells as a precursor for DNA, RNA, protein, and as fuel, and to the liver and the gut. It may reduce oxidative stress because it's a precursor of glutathione, and it reduces insulin resistance, as has been shown in several studies. Glutamine does more. It's taken up by the intestine, where it has been shown that glutamine-enriched parenteral nutrition protects gut barrier function. Glutamine is converted to citrulline in the intestine, taken up by the kidneys, and the kidneys make arginine from it. Glutamine also functions as a ammonia precursor to remove acid. So glutamine, there is a continuous glutamine cycling in the body, and this is a process that is difficult to understand why. So glutamine is a circulating signal, substrate, precursor, energy, and the idea is that the continuous cycling of glutamine makes the substance available for cells when it is needed. Well, I will now discuss three studies investigating the metabolic fate of intravenous glutamine in elective abdominal surgery repair, aneurysm repair patients, in enterally fat and parenterally fat intensive care patients. This study administers the day before abdominal surgery glutamine IV, and during surgery tracers of amino acids are infused for 2.5 hours, and then arterial and renal blood vein sampling is taken. The study shows, as was hypothesized, that glutamine supplementation enhances renal arginine production, at least in surgical patients. So the beneficial effect of glutamine in surgical patients could partially be mediated by increasing arginine production, which is an important substance for protein synthesis, and it's also a nitric oxide precursor, and thereby may influence inflammation, immunity, and organ perfusion. This study has not yet been published as a full paper, but has appeared in abstract form. And what they did, these were enterally fed in intensive care, non-septic intensive care patients, and they received at about day 5, and one group was fed without and the other with supplemental glutamine. And there was a crossover of tracers that were either infused intravenously or enterally. And the study found that endogenous appearance of glutamine, arginine, and citrulline was not different between groups. So the glutamine-enriched enteral nutrition in critically ill patients did not reduce endogenous glutamine generation and did not increase arginine production, as has been shown in the surgical patients. So something is different in the intensive care patients and in the surgical patients. This is another study. It's published this year or last year. ICU patients received parenteral nutrition without glutamine and labeled glutamine and phenylalanine was infused. And this was in a, nutritional dose, the glutamine. And the research question was whether glutamine could reduce de novo glutamine production. So if we give glutamine, can we reduce muscle proteolysis? Said in a different way. Well, the study found, as we can expect, that glutamine infusion increased plasma concentration, but unexpectedly, despite a higher plasma concentration, endogenous glutamine appearance increased and did not decrease. And protein degradation did not diminish. Thus, despite a higher plasma glutamine concentration, protein degradation was similar and de novo glutamine production was slightly higher. Well, it's at least a question mark. So the tracer studies show that glutamine does not inhibit proteolysis in ICU patients, does not reduce and even may increase endogenous glutamine generation, and increases systemic arginine generation in surgical patients, but not in intensive care patients. Well, let's go to the recent large randomized controlled trials, the REDOX and the META-Plus trial. The REDOX trial, you all will know, included ventilated patients with multiple organ failure. It was a 2x2 factorial design, and it compared glutamine, antioxidants, the combination, or placebo. They gave, and today I will only talk about the glutamine. They gave glutamine both enterally and parenterally in an extremely high dose. So let's say in a double dose as is normally advised. Very high dose, and they gave it as a supplement, not as a component of the feeding. And if we look at the results of their feeding, we see that, well, feeding goals were poor. Only 40 to 50% of the calorie and protein target was attained. The primary outcome of the study was mortality, and they found that overall glutamine administration was associated with an increased mortality. It was a p-value of 0.05, so it tended to be significant. And they also showed that, especially in the group of patients with more than 2 organ failures, glutamine was harmful. So this may be a clue. And the conclusion of the trial is that the early administration of glutamine in critically ill patients with multi-organ failure was harmful. Well, there was a really hype and discussion what could be the explanation, and many suggestions were done. The dose was extremely high. Many patients were not glutamine deficient, as we found in a Dutch study and a Swedish study, and also a subgroup of this study. Only 25 to 30% of the ICU patients is glutamine deficient, but they could not link toxic effects to supraphysiological doses. Glutamine was administered as a supplement, and a rather high proportion of patients were not well fed, so the amino acid composition was totally unbalanced in these patients. And this is probably very important. These were patients with severe multiple organ failure. Apache 2, 26. Well, let's go to the second study. It is a randomized, controlled, multi-center study, including the same type of patient, but severity of disease was slightly less, and there was a randomization for enteral nutrition, two types of enteral nutrition, an immune-enhanced formula. Both nutrition formula had similar amount of protein, but immune enhanced, this was only casein protein, this was casein but also glutamine. And this nutrition also had some glutamine. Carbohydrates were lower in the immune enhanced nutrition because there was more fat, and that fat was MCT or fish oil, and there were some differences in vitamins. And the primary endpoint was no infections, and there was no difference in no infections. Of note, many patients already had an infection at inclusion, and 75% received antibiotics. And this was again astonishing. They found a higher mortality in the medical patients and similar mortality in the trauma patients. And in this study, glutamine was part of the enteral nutrition and was administered in a nutritional dose. And at multi-Cox proportional regression analysis, they found that the immune-enhanced nutrition was an independent predictor of mortality, independent from age and Apache 2 score. And they looked at some subgroups. There was some impression, but this was not significant, that there was some benefit in the patients with low plasma glutamine, so they measured plasma glutamine in all patients, and there was more harm in the patients with high plasma glutamine. So this makes some sense, but the difference, it was not significant. And well, the oldest group of patients had most harm, and perhaps there is some trend that there was more harm in the higher aged patients. And well, this is not a clear relation, but in the middle Apache 2 groups, harm was highest. But there is no linear relation with severity of disease. Well, what's the explanation of the glutamine paradox? And that's what we thought. We went back to the older studies, that during sepsis and cirrhosis, there is increased proteolysis, and the reason for this proteolysis is that glutamine is needed for the immune cells, which are very active, and they need it for energy and precursor of DNA for rapidly dividing cells. And immune cells make cytokines, and cytokines are the reason for the proteolysis. It's due to the cytokine release that there's proteolysis of muscles. So if we provide much more glutamine, it could be that immune cells become more active, and make more cytokines, and there is reason to believe that they do so because cytokine production is glutamine dependent in a dose dependent way, at least in the in vitro studies. So the idea is that in patients with sepsis or systemic inflammation, glutamine might increase immune competence. That's why we thought that it would be a good idea to give glutamine, but also fuel the inflammatory response. Well, this is a hypothesis. And if you do this, then you could give more harm. So interference with glutamine in the inflammatory cascade gives unpredictable results. So let's conclude. Does glutamine still has a part to play? Well, I think that we should not administer glutamine to patients with severe organ failure and in the acute phase of sepsis or SIRS. That IV glutamine as a component of parenteral nutrition in GI surgical patients perioperatively could be a good idea. And deliver glutamine in stable ICU patients? Well, in fact, I do not know. But I would be very reluctant to give it in the acute phase of the disease. And there could be a place if the patient is recovering. Thank you for your attention.
Thank you very much for this nice overview. Yes, please, a question. First row.
What's about the use of glutamine in trauma patients?
Yeah.
You didn't mention something about trauma.
Trauma patients are included in many of the meta-analyses. In fact, there was benefit in trauma patients. You can say trauma patients have SIRS as well. You should look carefully at all these studies, at what time the glutamine was started, because parenteral nutrition was initiated on day 3 or 4 perhaps, at least 5 or 10 years ago when most of the glutamine studies were done. So they do not all give their glutamine very early. But the whole point is that it's probably it works in the trauma patients. But there, if we look at a META-Plus study, they looked at the trauma patients and there was no difference in mortality and no difference in infections. So, well, what has changed in the last years? I don't know. Perhaps that we start feeding earlier, that our patients have less energy deficit or protein deficit. I don't know. But there is a difference. But I think there is something with glutamine and inflammation that should be considered.
So having said that, what about the effects of glutamine on the enterocytes? This may be another way of thinking to believe that enteral glutamine may help enterocytes and could be used within the GI tract and not delivered to the circulation.
Yeah. Well, of course there are studies with parenteral nutrition, and if you give parenteral nutrition with glutamine, there are studies that gut barrier is better. With enteral nutrition, at least part of the glutamine is utilized by the enterocytes. Well, in the META-Plus study, it showed no benefit, at least. And there are also tracer studies in animals and in septic animals. And when they give glutamine to septic animals, the glutamine is taken out by the liver, but not by the enterocytes. And that study that has appeared in abstract form only, these were enterally fed patients. And if you gave, well, that was enteral and parenteral labeled amino acid, there was no difference in citrulline concentrations. And well, it's very difficult. Lot of question marks.
And maybe my final comment or question could be: would you recommend for future studies to check the plasma glutamine level before starting any supplementation?
Well, I think that's the basis, and that's the reason why we measured plasma glutamine concentration at that time. But then we found the lowest plasma concentrations in shock patients, and I think. They included the shock patients in the redox trial, and but at least if you do an intervention, you should measure concentrations. That's the minimum of understanding. But I think there are a lot of questions.
Yeah, just to try to answer the question, maybe the next trial should select patients with only low glutamine level and try just to homogenize as possible maybe the administration, because on the second study there is just control, and you compare with immune enhanced nutrition with glutamine, but also different components. So I don't think that we can say that maybe glutamine may be harmful on the second study, because there is too many differences maybe in the two.
Yeah, if you do a study, you should change just one component. Yeah.
Only one, yes. That's the main problem with immunonutrition study. Every time they just want to compare just the normal nutrition versus different components.
Yeah. The idea was, of course, that all the components would benefit patients, and that the benefit would be higher with a combination of the components. But it's for understanding pathophysiology, it doesn't help us. Does glutamine still has a part to play? Well, today we will discuss why glutamine is an issue. I will discuss some metabolic pathways, and then two confusing studies with results which were quite contradictory to previous studies.